Advances in hip arthroscopic capsular management. Recently, more attention has been focused on capsular management in the setting of hip arthroscopy. The goal is to improve outcomes and decrease complications. This video presentation highlights some tips and techniques for capsular management during hip arthroscopy. This particular patient is a 20-year-old pre-professional ballet dancer. She has had chronic left hip pain for greater than 2 years. Global signs of ligamentous laxity in this patient include hyperextension at the knee and elbow. The patient's hip is easily distractible even in abduction. This can be shown on this C-arm fluoroscopic image. This is a secondary sign of capsular laxity. The anterolateral portal was developed in typical fashion using C-arm fluoroscopy and a nitinol guide wire. For anterior portal placement, I used a spinal needle. However, in cases where capsular plication is likely to be needed, it is important to go as inferior as possible away from the capsular insertion on the acetabular side in order to have enough cuff of tissue to later hold sutures. Having a larger superior cuff of tissue can counterintuitively make acetabular access easier, as the arthroscope can go underneath the capsular tissue and retract the superior capsule. I slid a cannulated knife over the nitinol guide wire in order to do my anterior capsulotomy. Again, I am trying to stay as inferior as possible on the capsule. Through the anterior portal, I am using the cannulated knife as a switching stick to put in a metal viewing cannula. We are now viewing through the anterior portal, looking at my anterolateral portal. While the portal position is centered between the labrum and the femoral head, in cases of capsular laxity, I want to be even more inferior than that. I'm going to take out that cannula and then reposition it through the capsulotomy that I made anteriorly in order to finish my capsulotomy anterolaterally. In order to increase exposure of the femoral head-neck junction, I typically use a 70-degree suture passing device and put in capsular stay sutures both anteriorly and anterolaterally in order to increase exposure by using these sutures as retractors or capsular stay sutures. I'm using a crab claw device and taking out the suture through my anterior portal and doing a suture shuttle of an ultrabraid suture. We are repeating this process anterolaterally using a suture shuttle technique. You can see that now I have complete control of the inferior capsule, and I can use this as a retractor in order to get full exposure of the femoral head-neck junction. After performing labral repair and osteoplasty, an X-ray was obtained, and you can see that the hip is subluxated even without traction applied. Now, once the patient starts to actively engage her muscles, that laxity would disappear, but this demonstrates that the capsule does have a stabilizing effect on the hip. Now we're going to be performing a capsular plication. The patient's hip is flexed at 30 degrees. I've used a 70-degree Accupass suture passer to put in a suture through the superior capsule. I am now going to use a bird beak and penetrate the inferior capsule and then perform a suture shuttle technique to pass an ultra braid high tensile strength suture through both the inferior and superior leaves of the capsule to tighten and plicate the capsule. This is a picture of one of my knots on the peripheral side of the capsule following plication. Here is an x-ray taken after completion of the capsular plication. You can see that the apparent subluxation of the hip that was visible on x-ray before the plication has now been eliminated. The hip capsule is a functional part of the hip and not just a barrier to get through to access the hip joint. With advances in instrumentation, optimal capsular management for each individual patient is possible.